topics we've talked about before, including urine toxicology and complex patient management, this is probably one of the most challenging issues that's being addressed in our country today, and one of my favorites. So I'm happy to present it. I often tell people that what the opioid crisis has demonstrated is our lack of access to substance use disorder treatment broadly. That's always been a problem, and so it's not necessarily that the opioid crisis is its own thing. It's kind of a complex subset of the issue that we don't have appropriate access for SUD treatment. I also tell people that, as I've worked for many years on healthcare system integration pursuant to what many people think is the right thing to do, and was further codified in the Surgeon General's report in 2016, we don't necessarily have to reinvent the wheel exactly. And I'm going to talk about that today, where we've gone from periods of time in kind of American medicine where we had little to no coordinated care for complex disease states such as cardiac disease in the 60s, to a wonderful spectrum of care almost anywhere in the United States at this point. And so we have some paradigms and some frameworks we can work from to talk about this issue. Today I'm going to review the basics of treatment, although that will probably be brief for the group. It seems that the folks on the conference today probably understand that. Describe the continuum of SUD treatment services as defined by ASAM and others, and as I understand it. Design some program components to fit in available treatment models in the community, meaning looking for what you have and what you can plug in quickly versus what's a longer term development issue, and then identify kind of innovative ways to deliver services in integrative versus collaborative models, including things like telehealth. So to refresh for everyone, as this is my mission in life, to always define treatment the same as biopsychosocial. That includes both medical. Sorry?
You run into all this echoing and you can't hear this.
Yeah.
Could you, those of you who aren't presenting, could you please mute? Thanks.
Sorry about that. I thought it was a question. So reviewing biopsychosocial treatment, of course, at least as best defined, again, by the entities described, it's medical treatment in conjunction with psychological and social interventions and management, as you see here on this slide. Medical, in this case, for opioid use disorder specifically, of course, means medication-assisted treatment, almost without a doubt, at least offered to the patient and managed carefully by the medical practitioners, whether they be physicians or advanced practitioners. And then psychological interventions by the appropriate educated individuals in the region where you're at, which may include chemical dependency counselors, other types of therapists, psychologists, psychiatrists, etc. And then one of the most important components, of course, in dealing with coordination of care for a patient is the social work and case management folks, which we can and should rely upon heavily if they're available. One of the reasons that access to treatment continues to be a problem, although we're seeing some substantial upticks in this, and that actually, full disclosure, the data on the left of your screen, MAT providers, is a little old. It's now in the mid to upper 40s, 1,000 MAT providers with a license. We still know that the vast majority of them are not actually using them, or if they are using them, they're using them minimally. So even if you have 30, 100, or 275 limits, very, very few folks are anywhere near that upper end. Here in Ohio, actually, we've trained over, I think there's about 500 providers, and the utilization has not been where we would like it to be, but I think that's because getting the training is just one piece of the issue, getting the data waiver training, while actually getting into practice, understanding how to see patients, getting a regular rhythm of doing so, and managing them is a different thing. So I think, still broadly in the United States, we know that no more than 20% in any area of patients are getting opioid use disorder treatment with evidence-based medicine and medication. And so we have a long way to go in the capacity building situation. It is important to note that patients should be put into levels of care, which we're going to talk about the continuum in a second, by the ASAM criteria. This is probably the most robust, if not definitively the most robust set of placement criteria insofar as its duration of use. The studies that have evaluated it and that continue to go on and placing patients in the right level of care. The reason that's important is because, at least in the public, and again, this is a conference of, I would say, learned professionals, but in the public eye and in many public, so governmental situations, people often use the term beds. We need more beds. Everyone has to have bed capacity. Well, that may or may not be true. And in the broadest utilization of the ASAM criteria by a database, which is not yet necessarily public knowledge, but over 200,000 assessments that have occurred in a certain part of the area, we know that residential care as a part of the spectrum is actually a small subset of the necessary treatment, and that it doesn't necessarily bode longitudinally better for patients. So being able to explain the fact that there are multiple levels of care, and that patients should be placed in them and, quote, right-sized, because they actually do worse in both too high of intensity, as you might understand, and too low of an intensity, as you might understand. It's important to know how to place those patients. People often don't necessarily readily accept or understand that if you put somebody in residential when they don't need it, they don't do well. But if you think about it on a granular level, for a specific patient, if they have to leave their job, which is stable or barely stable, and arrange childcare and disconnect from their family and everything else that was going reasonably well, and they don't need residential, but they're put there for any number of reasons, including profit motives of the residential facility, then they actually do more poorly if they've been placed in the right level of care in the first place. So it's an important concept. One I've mentioned, and I have no financial relationship or duty to the ASAM Continuum engine, but that is a electronic version that is now available to help clinicians place patients in the right level of care by the ASAM criteria, and it is really functional when used appropriately. So if folks haven't seen the ASAM Continuum engine electronic version, it's a really nice way to go about using the ASAM criteria, which heretofore have been primarily done on paper. All right, this is probably the most important slide that we're going to talk about today, and I didn't include all of the sub-levels of care and ASAM criteria that you are welcome to look at on the ASAM website, because I think it's important to get a base level understanding, and you can talk about the 3.1 versus 3 point such and such, and whether a patient needs subacute detox or whatever else. But thinking through the ASAM levels of care in the treatment site, this is really the continuum that needs to be built. Today, in many different areas of the country, I'm sure including North Dakota, you have some pieces of this. Rarely have I ever seen a coordinated, I would say almost never actually, seen a coordinated continuum in any one area for the patients. Now, speaking to that just for a second, you may see a residential that is at a faraway place and the patient comes back, transitions to intensive outpatient and on through the continuum, and that's okay. And that's what speaks to kind of using what's appropriate and necessary for the patient and developing a patient-focused continuum as opposed to having it all in a community. And then that's one way to look at it. We'll talk a little bit more about that in a second. The other thought process is that most patients actually summarily do best in getting into treatment and recovery in the community that they're in, because of the concept that if they go away to a quote magical place that is residential treatment and they do well for 30 days, they come back to their home environment, they're not often yet skilled enough to manage that environment that they normally reside in. Meaning it takes a certain level of development of recovery in order to be able to be in the environment you came from, regardless of whether that could have been a stable and loving home, but more often than not, it's a tumultuous environment when people actually transition to needing treatment or are identified to need treatment, unfortunately. On that one point, as we develop a continuum of care, I think it's everyone's hope that we start identifying patients earlier so that we are intervening on patients that are in level 0.5 or level 1, and that we have much higher success rates intervening earlier, much lower resource needs, so you don't need a triple boarded addiction psychiatrist to see somebody who basically would be at a level 0.5 and probably just has opioid dependence issues. And so it's important that we, as we develop and think about this continuum, that a large part of effort and thought is put into developing the lower end of the spectrum and earlier identification. So we have good identification tools. I recently learned that Epic which is our primary EMR in this part of the country. And Andy, if you might remind me, do you guys use, is that Epic a primary EMR up there for you guys? They're pretty common.
Yeah, very common.
So Epic has the ability to turn on for any system the NIDA quick screen, which is a really good 4-question sequence screening. So if it's positive and leads to other interventions, et cetera. And I would advocate for any group that is in control of, involved with, or working with any health system on how to manage some of this issue, that they look at those screening tools that are available. I had a conversation with a large healthcare system here in Ohio, was lecturing to a huge group of nurses, and I'm married to a nurse, and I was raised by a nurse, so I know that putting more absolute or necessary or non-surpassable screenings on their intakes is the last thing you want to do for a nurse right this minute. I was present when we went through the Ebola, I would say, boondoggle here in this country, and remember what that did to all the staff. And so I said to the nurses, really, what is the primary thing that would drive you to want to do this? And they said, if I were to identify somebody with a problem, I need to know I can get them into treatment. And it was pervasively their concern about adding more screening. So I think that's an important kind of 1-2 concept where I think, I would advocate for more universal screening, with the understanding that if it's ever implemented, it needs to result in something actually happening. If you look at the literature for SBIRT, the problem is not the screening and brief intervention, it's the referral to treatment piece. And so, folks who focus on SBIRT much more than I do continuously say it's the broken RT. And so in thinking about a continuum such as the one on the screen now, we really do need to make sure we put a substantial amount of effort into that kind of lower end of the spectrum as well, I was just speaking to. To go into the other end of the spectrum, I'll talk about beds a little bit more. Don't get me wrong, with IMD exclusions being lifted and people having, being able to develop more residential treatment, potentially over 16 beds without violating a federal law, there will be more residential bed development, but it will be somewhat slow because you're talking about capital expenditure and billing and development, et cetera, all else, and the capital expenditure is fairly high. Good news is we need more residential / inpatient treatment, but we don't need as much more as many people think. Not every person with OUD needs a residential stint. In regards to the inpatient part of the spectrum, we have demonstrated here in this region that actually with just some substantial effort and training of the hospitalist, as well as protocols in your EMR, you can actually do a fair bit of inpatient detox without building a quote detox only facility. You really just use unused hospital beds and protocols, and the hospitalists and psychiatrists managing that process, and inpatient detoxification can be built fairly quickly. We basically opened it on demand everywhere throughout Cincinnati with 2 systems in under 2 years. It's a pretty big endeavor to do, and I do realize that I'm substantially aware or acutely aware of the fact that I work in a city, which is not always the case for everyone. In regards to the hub, and I know that there's been some hub and spoke efforts in your old state as well as many others. I'm sure you've read about it. I'm going to talk about that next. And I think that is absolutely the right way to look at development of services, including utilizing telehealth, et cetera, because there cannot be a hope that you're going to develop a hub of intensive addiction treatment in every town in North Dakota. It's not going to happen. In fact, probably very few of them. But they're necessary for folks to refer to and manage patients when they're sickest, and to have resource and access to things like this echo clinic, so that they could talk to someone like myself. I have this real complicated case that really like to talk to you about, or send to you if that's at all feasible from a distance perspective. So let's talk about the hub. Interestingly to me, every time I look at treatment access service development, I think back to what I said at the beginning of the presentation. We should really not try to reinvent the wheel and look at other frameworks and structures that have happened across many decades, and try to replicate those to the best of our abilities, as opposed to making new things up, which we see going on across the country, promulgated by people not thinking in the way that I'm discussing this, as well as grant funds being thrown at things that don't make any sense. I would say that the Echo Clinic, as well as other telecommunication and telehealth efforts are not an example of that. That's a very appropriate and efficient extrapolation of resources, because I don't live in North Dakota. And so getting me on this, if we were to try to have a conference with all of the folks on the phone in North Dakota, I imagine it would happen once a year, as I believe it's happening for the next few days. And so this is a very appropriate use of those efforts and those monies. But this thing that I have on the screen here between the endocrinologist, patient, and the PCP is not at all confusing or new to most folks. That doesn't mean there's an endocrinologist available everywhere you want one all the time, nor is there a neurosurgeon, et cetera, all else. But to some extent, we've been able to build the capacity to treat complex diabetic or other endocrine disease by using this framework. And that's exactly how we should do this. And we should always keep these two slides basically in mind anytime we're thinking about the development of services in any area. All right. This is a little bit of a stepwise, again, just to be very direct and honest. Building a continuum of care where you're at is its own thing. So you can only start with kind of what do we need, and just say, sorry to go back and forth so much, but we need this. Is that achievable in our area? Are we in too rural of an area to expect all of this to occur in that place? Does that mean we send people off? We use telecommunication for some things. So what do we want to do? And that's the spectrum there. And then what do we have? One of the most interesting things that I think I've learned over the past several years in working in the field is that often people don't even know it is present. And so there are monumental efforts to define what is currently present in place. Now that is a little bit of a challenge because not everybody registers their treatment facility or themselves as a medication-assisted treatment provider, et cetera. And so you may or may not find them on things like the SAMHSA Treatment Finder. There may be criteria that they don't qualify for that would prevent you from finding them on a registry, et cetera. But I would say that even 5 years ago, there was little other than SAMHSA Treatment Finder and a few other things. There was little to no attempt to even quantify what it was in a region so that a system or a provider could refer to them or anything else. Now we have the Addiction Policy Forum. If you have not seen, I believe they've done all 50 states at this point or somewhere near all 50 states, a lot of them. They have spent a monumental amount of time, effort, and money to try to find treatment providers and put them in a place. And then somewhat quantify what it is that they do. And there are a few other national treatment registries that are going on. And so I'm happy to say I think we're in a much better place from an identification standpoint than we were a few years ago. Interestingly, folks in one community often think they know exactly what is or isn't present, and that's not always true. Some providers are not particularly forthcoming, which usually means that you wouldn't want to interact with them, and that's an interesting paradigm. But sometimes it's not. Sometimes medication-assisted treatment providers, there's still a ton of stigma attached to being a medication-assisted treatment provider. I know, I deal with it all the time. And so it is important that we continuously remove that and encourage people to come out, talk about what their program or if they're just a private practitioner are doing, so that they maybe become part of that continuum as a piece of it. I'm going to go back for just a second and talk about that piece. I wanted to say one thing here, which is the fact that we have a new ASAM AMA payment model that has been published. If you haven't seen it, you can find it pretty easily by Googling that phrase. The point of it was to develop a payment model that was flexible enough to deal with an agency or an entity that does everything kind of in one house and only in the spectrum of levels 2 down, so only IOP down, not residential and inpatient. Or if you were to happen to have a couple of counselors or a counseling agency who coordinates with a medication-assisted treatment provider, that the payment structure would support that coordinated care. So when I say things like integrated versus coordinated, I mean integrated is all in one shop, coordinated is as I described it. So it's important as communities, agencies are looking to expand, this continuum, that they think about not having to have everything in one place, everything under one roof, so that they can serve the continuum best. Now, I practice in an integrated environment. I really enjoy it. I probably wouldn't practice in it. Well, I don't have to practice in a coordinated environment. But we know that that's not reality, and I deal with other agencies who do all the counseling and some of the other therapies, et cetera, and their medication-assisted treatment provider is a private professional who works there but is not an employee. So I encourage people to be open-minded in developing this continuum and thinking through how it can be manufactured. So back to healthcare system integration, I've already spoken to that somewhat. There is not always a need to build new beds. And so people should always ask when someone says, well, we need to get more money, which is always a problem, to build, quote, new beds. We need to think about whether that's actually true or not. I recently reviewed the Interqual and the Milliman criteria, as well as Beacon Health, CareSource, and many other payers that allow for inpatient detoxification of any chemical, alcohol, opioids, when medically indicated. And it has some pretty, I would say, broad criteria that allow for admission of patients when necessary, and therefore theoretically getting reimbursed for that. That is a new concept for most healthcare systems and hospitals. And I encourage folks who are working in that part of the environment to read through those things, because I've just done it with 2 different health systems, so that they understand that it's no longer something that you can't do. And it's definitely defined what you can do, and it's defined so that you can get reimbursed for it if you're a health system or hospital. And so that could help. And understand that, and I've mentioned this before in previous lectures, detox alone doesn't work. So there's no point I wouldn't say no point, but that's not the appropriate thing to develop, is detox services only, which is happening. And you may see profit-only driven organizations that are popping up in different hospitals. Also not appropriate or necessary. The health system themselves should really endeavor to do that. Insofar as other healthcare system integration, parts of the continuum, the emergency department is a part of this continuum. So despite the fact that it is not sitting on this slide here, the emergency department, I'm not saying that because I'm an emergency physician also, the emergency department is absolutely part of this continuum. A ton of our patients touch that area, that acute healthcare setting. And we just released, I think last week, a new article in Annals of Emergency Medicine, which the link is here. But if you Google Annals of Emergency Medicine and identification of patients with opioid use disorder and management, you'll find it. Good news, I don't know how these things happen, but Annals decided to make that an open access article. So just a few days ago, it was something you had to pay for if you didn't have access to Annals. But now it is an open access article, and the authors, including myself, pushed for that. Again, who gets to make that decision, I don't know, but I think it was based on the importance of the publication. So I think that's great news. Everybody have access to that and should share it with their emergency medicine colleagues. Also, FQHCs have done, I think, a great amount of work in a relative space. Few of them have done substantial work in the substance use disorder treatment space, specifically MAT. Some of them have, but not the vast majority. But they have been working on behavioral health integration. And so using that as a springboard, and I'm going to keep going back to it for reference, using that as a springboard into developing services for medication-assisted treatment, it is not a huge lift. It is a lift, but not a huge lift for those FQHCs with integrated behavioral health to move into level 0.5, potentially level 1 at outpatient. And then depending on their capability, creeping up the spectrum, obviously not doing residential inpatient, but potentially even offering and becoming a hub, which some have, and developing the most intensive PHP, IOP, et cetera, services. So FQHCs are an opportunity to move, and they have funding specifically directed for SUD, for medication-assisted treatment development, and in general behavioral health integration. One key point here before I finish this slide, you must have prescribers of medication-assisted treatment. I mean, that has to be a piece of the puzzle that is developed. Training programs are going on throughout the country, ASAM, the APA, lots of different entities have gotten funded to expanding the training, and then and the online training to start, and then both for physicians and advanced practitioners. Then I always say 8 hours is not enough to make you an expert. Please don't assume that. I don't think anyone who takes it and is trying to see patients with OUD think that. But programs like this ECHO are really important and monumental in supporting those physicians. So my organization, Brightview, has an addiction specialist hotline that we offer to different health systems so that when they get physicians trained who are working in an inpatient setting, ED, TCP, whatever, they can call in to us with patient questions, and we have a cadre of addiction specialists on call for that effort. So it's important to have those support systems, because what we find post-training most often complain of why they're not prescribing is, I have no idea how to do this really, not the support.
Dr. Ryan?
And then I'm going to, yes.
There's a quick question. As we're talking about the number of prescribers and trying to increase that, the questioner asks, with the 100,000 prescribers that you mentioned, does that include nurse practitioners and PAs?
So it's a little bit over 40. I think we're in the 46,000 range now, not 100. So if we're talking about, I'm going to go backwards just a second. This slide here, when I did this slide, we were at 44. I think we're at 47 or 48. It's a little tough to track as quickly as they're coming on board. There was a SAMHSA email yesterday that I'll forward to you guys that talked about the increase in medication-assisted treatment providers and how many of them were physicians and how many of them were advanced practitioners. When I made this pie chart, this was immediately prior to APs having the ability to do this. It's a little bit over a year old. So I will send that to you, Andrew, Andy, and Lisa for distribution. That recent report from SAMHSA. The overall summary of that, by the way, is that we've seen a substantial uptick. It was something like we saw more practitioners get trained in 16, I believe, than we saw in the previous 4 years, something like that. So really, really positive. But like I said, what we'll see, my understanding and from education and in medical education, is we'll see a percentage of uptake. What is most likely going to happen, just being realistic, is that we will see a little bit more of a disconnect. We'll probably have many more professionals trained than are using it for a time period, and some of them will filter in, some of them will filter out. And so we'll see what happens. I do not have any delusions of grandeur that everyone that got their waiver is going to start robustly prescribing medication-assisted treatment, but we can be hopeful. Let's talk about telehealth for a second. So telehealth has a lot going on. The technology is almost a moot point at this time, realistically. I remember years ago when we were just talking about it, we bought $50,000 telehealth machines. That was kind of crazy what we were spending on things that I can do on my phone now. So I did a Zoom conference like this one on my Samsung, Android phone the other day, and it was amazing. And so technology has become a little bit of a moot point, but the billing and the compliance has not. So billing is still significantly challenging for telehealth for many patients, especially for lower socioeconomic patients who might often have Medicaid or other indigent products, insurance products for folks that are indigent. Those don't often reimburse appropriately for telehealth. So that being said, there are movements and there are allowances in a fair number of things, and then there are state and federal efforts, including legislation in both environments, to move that forward to require parity type reimbursement with telehealth, so that if I were to see somebody non-physically for something that didn't require a physical visit, as well as following the compliance guidelines of prescribing, that I would get reimbursed as a professional in the same way as if we saw them physically. We're looking at this at our organization as we are expanding into rural areas, because I may need certain physician, like a board certified OBGYN addiction specialist, of which we have some, to see a certain patient, and that would be much better if we could do it both compliantly and legally, as well as getting reimbursed. And so I think that I'm very pleased with the way that telehealth is progressing. I think we got some more steps to go. One of the biggest barriers, and I'll apologize for the next slide in advance, has been the compliance side of buprenorphine prescribing at a state and federal level. So if you're not familiar with the Ryan-Haidt Act, I apologize for putting all of this on this slide, but I don't want to interpret a DEA email to you guys. So I wanted it to be the whole email if you're going to use this reference. And this was a clarification of their understanding of the Ryan-Haidt Act, which took quite some time. There are multiple other things. There's telehealth legislation to get further clarity. There's telehealth legislation to have a special registration for a DEA practitioner to allow them to prescribe controlled substances, such as buprenorphine. But as of today, the DEA has provided, this is the most recent, and I think it's only a few weeks old, clarification of the Ryan-Haidt Act and how one might use telehealth prescribing for buprenorphine or medication-assisted treatment. Important note, this is the federal rule. most often what I've seen, so you then have the State Board of Medicine or pharmacy of your state who will make interpretations of their own. They are not allowed to go less restrictive. They're not allowed at all, neither are you as a practitioner, even if they were to make that mistake. But they may go more restrictive. So some states, including Ohio, may be a little bit more constrained than what is the current number of CSA designations seen in this piece here. So that being said, this basically says that there are some limited situations in which you can prescribe buprenorphine to a patient through telehealth without a physical exam. And so I'm not going to read this whole thing to you, but it is important that if you're doing this currently, and I know practitioners are doing it without full understanding of the regulations, unfortunately, not maliciously, just uninformed. Or if you are planning on doing it, then anyone should be very aware of what you can and can't do. If you look in the middle, it talks about A and B, which are basically the two situations. I would say this is not the entire regulation. So I would encourage you to go back and look at the whole CSA, because you have to do some number of criteria, which are kind of normal medical practice of things you do for patients, like make sure you document it in the chart, et cetera. You have to, of course, use a telehealth platform that is capable of doing it. And then there are subset criteria. So if you achieve all of the first, you have to achieve the second, which are basically A and B here on this slide. There's a fair number of legal opinions on the internet, as well as I'm sure by local legal counsel that may help you work through this if this is a part of what you're doing. But I think we would all be remiss not to consider the possibility and opportunity of telehealth, especially in areas with more rural areas than not, like North Dakota, as a part of the continuum development, and saying that I have found a remote medication-assisted treatment provider. We're going to do some parts of the continuum, or we're going to make it work through the amalgam of those things. So I just wanted to bring that topic up. It's pretty complicated. If you're going to do it, I suggest you really do get to know what's going on with it. It's not as simple as what's happened. There have been people fined substantial dollars for thinking you can Skype controlled substances over a non-HIPAA compliant telehealth platform. So it is not to be approached without some reservation and understanding. In summary, not surprisingly, and this is probably the fifth time I've said to this group, biopsychosocial treatment should be the standard of care for OUD, including MAT. You should use the HM criteria to identify the patient level of care, which will help you both prospectively and retrospectively identify what parts of the continuum need to happen. So if you're using something like, let's say, as an example, if North Dakota decided as a state to use the continuum engine, again, I have no ties to that thing, but it works and it's a good tool, then they would know what development levels of care would need to happen in North Dakota, because there would be people coming in and it would be identifying levels of care that need to happen for those patients. You need to work towards building a true continuum. A lot of relapse occurs without a true continuum. I know that because I dealt with it much worse 2 or 3 years ago here in Cincinnati, where we didn't have a good continuum. It still has a ways to go, but patients often relapse in those gaps is the one way to think about it. And then we got to utilize innovative technologies and collaboration to fill those challenging gaps. There's absolutely no way we're going to have every medical service we need, including this one in rural areas of the United States, basically ever. So we have to understand reality and move forward with technology and collaboration to fill those gaps. And I'm going to stop there for questions, and I realize we'll have a panel discussion ongoing actually.
Great, thanks, Dr. Ryan. Any questions for Dr. Ryan? Many of you may be aware that we're going to be experiencing his expertise again in our region. He's coming to be the keynote speaker at the Rural Health Conference this week. So,
very, very shortly getting on a plane, in fact. Well, I think like an hour from now, having to leave.
So praying that there are no questions. Yeah.
No, I mean, definitely, it's a complex topic. We obviously want to.
Yeah.
Dr. McLean, this is Lisa. Yep. Do you want to speak at all to, I know you've spent quite a lot of time laboring over the Ryan-Haidt Act and trying to unpack that. Is there anything that you could add that's relevant to what Dr. Ryan talked to about the federal being a floor but not a ceiling, and that the state layered on top of that in terms of where we are in this state? Not to put you on the spot or anything.
No, that's fine. In fact, it's very ironic because in 50 minutes, I'm lecturing to the psychiatry residents on telepsychiatry and was trying to finish my slides, including the latest updates on Ryan Haidt Act. So Dr. Ryan's absolutely correct that there's a lot of interpretation, misinterpretation of the rules. And while the DEA has certainly said we're not going to come after people who are practicing medicine appropriately, that doesn't give people a lot of reassurance when they know that they're actually not practicing as the federal rules state. The other thing is states have also made changes in their legislation, but that doesn't trump the federal guidelines. So it's nice that there are recent changes, or at least clarifications in the Ryan Haidt Act. But I think people still need to be very cautious and follow those regulations. I think some of them are the DEA registrations. The dilemma in North Dakota is that the Board of Pharmacy does not have a way to designate those clinics to be eligible. And so that makes it difficult to follow these recent guidelines. The in-person evaluations, some people I think take advantage of what they're actually just doing coverage and become the primary provider, and they have not yet done an in-person evaluation. And you can slide for a while, but that actually doesn't suffice. And in addition to the A and B criteria, there are still exemptions, and in North Dakota is particularly appropriate as we have a number of Indian Health Service clinics, and those are some of the exemptions that are still in place with Ryan Haidt Act. But yeah, you want to talk to your legal group before you cross the line and start prescribing in ways that you want to interpret based on what's in the patient's best interest. There's still a need for clarification. Long story short. All right. Well, we have asked our expert panel, and it is a panel of experts. As you're well aware, this ECHO initiative is really in support of primary care, helping to enhance medication-assisted treatment, identification of opioid use disorders, et cetera. And so we thought it really important, as Dr. Ryan was talking about the access issue, of hearing from our experts in more rural areas or areas collaborating with rural areas on how you have managed to not fall into learned helplessness and actually get creative and innovative and found solutions. And so, here we beg, borrow, and steal from everybody else. So very interested in hearing about your expertise. And whoever is most uncomfortable with silence, if you want to start first.
Kurt, do you want to start first and just kind of talk about how you reached out and helped whole country and Valley? And then we can take it from there. Sure.
I took Dr. McLean's comment as a challenge, so I wasn't going first, I had to sit and be quiet. So yeah, my name's Kurt Snyder. I'm the executive director of the Heartview Foundation. I think that when I thought a lot about this issue, what stood out to me was really about relationships, and all the North Dakota SUD treatment providers have an admission process that's usually based upon a referral, a phone call, an admissions coordinator, a scheduled evaluation. And I think what really has been standing out for me has been that those relationships allow us to build new tracks around that. And I think that's an area that's large frustration for people outside of the SUD treatment world, is they call, and access to care is so hard. It's hard to get people in. So, we've done a lot of work to try to create easy buttons where, access goes back and forth, not necessarily through the process I described, but maybe nurse to nurse or counselor to nurse or physician to physician. And it's worked really well for us in that piece. With coal country, that's a great opportunity to talk about. I think that we were a part of training a group of physicians quite a few years ago at the state hospital, and I know Dr. Jackson is on, and I can't remember exactly when that was, but I'm thinking it was maybe 6 years ago even. And I think you guys are muted, Brandy, if he does remember when that was done.
Yeah, that was about 6 years ago.
About 6 years ago. And so we saw so many of those providers not enter into the prescribing world right away with this issue. So, we really partnered with Coal Country and helped to make an easy button, really tried to support their efforts with opening up our facility for them to come shadow us, creating those relationships between the professionals, and really even starting in a place where saying, hey, we'll do inductions to start with, or we'll do some of the treatment aspect initially. But they've actually gotten to the point where they do their own inductions, they do much of their own treatment services, and yet we still have this really incredible collaborative relationship where if we have somebody we're serving from their area, we have an easy button, and if they have somebody that they need in services with us, a more restrictive, I think they'd say as well that they have that easy button. Recently, we opened the same kind of scenario where Valley Community Health came and toured our facility. I think there was maybe even 6 or 7 of them, and really just tried to connect them with their peers, if there were nurses or the prescribers or the behavioral health specialists or case managers, and just to allow them to really see what it looks like in the work that we were doing. And once again, create those relationships and hopefully those easy buttons that I'm talking about. And a good example of that too would be real recently, we've been working with Sanford Health here in Bismarck to identify pregnant females that OBGYNs are working with there, and that they have, the access to our services as well as, ongoing care. So they're actually going to start prescribing as well and do, I think, up to maybe even 6 months postpartum, and so that's been just really effective to those relationships create those inroads, and you're not left to that call in an admissions process. I do want to share one more story, and then I'll quit. Actually, I've always advocated and pushed for treatment providers to reach out to healthcare. I think that we've always been in a position to say, hey, here's how we can help you. However, that's not how we entered this. Actually, in 2004, early 2004, we were approached, Heartview was, by a local provider, physician that was doing buprenorphine. So he was a trailblazer. I mean, it was only FDA approved in 2002. And he came to us really without calling or anything. He just came off the street and he said, I need help. And some of his issues were, he felt like he was being lied to by the patients. They continued to use. He felt like he was being conned, finding it hard to set limits and hard to set accountability. And really, he was just trying to do the right thing. He knew that the science was behind it. And so we started to have monthly sit-down meetings with him where we developed memorandums of understanding, patient contracts, and really exposed him to the world of drug screening that was required in this population to really understand, of what else they were using, which was This was prior to the prescription drug monitoring program, even in North Dakota. And so it's interesting that that's how North Dakota, or how Heartview entered into this, is that we were approached by healthcare. And then, you know, he moved out of our community and we started our own program in 2010. So I'll be quiet.
And if you don't, no, I just want to mention something that Kurt said that is key. Easy button. When we started our program here in Cincinnati, it was 6 month or 6 week to 6 month wait. Over the past several years, it's now none, literally for almost everything. Now, for some residential, at some periods, we'll have a spike where it may not be available, but then inpatient detox is available at a hospital. But the way we started was we said that we would answer the phone. Such a simple concept to make an easy button. And we now have an active 24/7 hotline where anyone in the community, patient or provider, can call and get an appointment the next day, same day if it's early in the day. And so that concept of easy button and not being, you know, not letting perfect be the enemy of the good is so big, because people are, I guess, overworked. We all are, you know, that's a statement that can be made. But then the kind of the intrinsic stigma against trying to help a patient, I would say, may prevent, as an example, an emergency provider from taking the time to go through 10 calls and do all that other stuff. And so the easier we can make it for people to refer folks for treatment, many more folks will get into treatment. I just wanted to make sure that, I mean, I can't advocate enough for the easy button. Kurt, thanks for mentioning that.
And if I could just tag on to this, Lisa Faust, I want to bookmark a question for Kurt that may or may not be answerable at this moment, or maybe later in the panel. But I think from the vantage point of the substance use disorder provider, what do you think would appeal to those providers in terms of how does primary care do the ask? How does primary care begin to reach out and advocate for the easy button? Because as both you and Shawn have alluded to, there's a golden window of opportunity when patients present in crisis with a substance use disorder, and you quickly lose that window because of our treatment access problems. So if you can think about what is it that primary care can do and should do to engage treatment providers in a mutual sort of challenge to improve that over time. Does that make sense?
It does, and I think I could answer it right away. Actually, it was a part that I didn't talk about already, but it is, I really believe that the relationships are mutually beneficial. In North Dakota, probably about 90% of our treatment providers do not have a medical director, and yet probably all or most of our patients that we serve have unmet healthcare needs. And so it is a mutually beneficial relationship. And so in any of those relationships that I've tried to develop, I always got what we would need in mind, but I always think about what can we do for you. For example, I've had many substance use treatment providers come to me and say, I cannot find a prescriber that is willing to do the extended release injectable naltrexone. So, and that's a very, very effective medication for chronic alcoholism, for the opiate addicted population. But I think that the providers in North Dakota are open to working with medication assisted treatment folks, but they don't have the prescriber. So, you know, that easy button, what's nice about it is that it can go both ways. So those folks really do have patients that could benefit from that easy button of being able to be seen in a healthcare system. So I think that part of it is that we have something to offer each other.
I would also add to that, Kurt is exactly right. Here in Cincinnati, one of our key successes has been, as an example, we have multiple pain providers, way less than we used to have, and probably this pendulum has swung too far, but multiple pain specialists who are looking for somewhere to send their patients. Our patients on the treatment side also have painful conditions because that's how, half, if not more, the reason they got in trouble with opioids in the first place. And so we went to them and said, what is the two-way street here? You want to send people to us for assessment to help you determine if they have SUD or not, and potentially manage their opioid dependence. And we need patients who need better pain treatment, not with opioids, but through other modalities. And it's exactly right. Finding that two-way street is a key collaboration that has to happen whenever you're thinking about building that continuum.
So our Coal Country champions and Valley champions as well, comments on how you crossed that line and started, what you found has been helpful, what's missing?
So I'll go next. I'm Chastity from Coal Country Community Health Center, and our team is also back in Beulah. We've got Dr. Jackson, Dr. Plocky, looks like Brandy is there, our behavioral health care coordinator. Looks like Deb is there, and I think Missy, our licensed addiction counselor, was there also. So I'll just kind of talk about where we started. Again, FQHCs are have an abundance of access to additional grants. We did write a grant several years ago, and I think one of our foundations was we had true behavioral health integration already in place. We had a individual, Missy Herman, who is an LAC and an LICSW dually, and so that was I think a positive for us. We then kind of pushed the envelope further by hiring an additional person to kind of manage and care coordinate our patients, and that was our behavioral health care coordinator. And that position, I think, is instrumental in making our program a success today. She pretty much takes care of every patient, coordinates their care, whether that is helping with prior auths, helping for the intakes, and the follow-up after visits are occurring. In addition to our team of physicians and nurses, it's a strong collaboration that we have. I'm working with Heartview and working with other professionals across the state. I think starting for us, a lot of training was provided online, and we could access additional training from our regional primary care association. We went to several conferences to do some of that training, and then online, of course, through SAMHSA and the Data 2000 waiver. Although the physicians took the training to receive their waiver, we had all of our staff, our nurses, our behavioral health care coordinator, all of us took the training, so we all were kind of on that same page and understanding what the training was. In addition to the waiver training, we've done SBIRT, motivational interviewing training, just really trying to understand the concept of whole person care and not just that patient coming in for opioid use disorder, substance use disorder. In the beginning, fear, we were scared. We did not do inductions, as Kurt said. And I think that was just the unknown. We're a bunch of nurses and providers who really weren't aware of what was all involved. And once we began down the path, I don't think that there was much that we encountered for problems. And now inductions happen, on a weekly basis. And so that the fear has kind of subsided, and we've become comfortable with caring for patients. I think another true point of help, again, was Dr. Hankey at Heartview and her team. They were very open and willing. Every time I called Kurt or we discussed, there was never well, we'll see. It was always absolutely come, we'll help you. And I think that easy button is still there today. It is back and forth. As Kurt had said, another help that Heartview has done for us is provided a locum, if you will, addiction counselor during times of need that we needed to have that specialized service available locally. And so that again, was a true help for us. Without addiction counseling and the intake for drug and alcohol evaluations, we couldn't have continued on with our program. And so that truly has been a help along the way. Some additional challenges I think that I'll talk about are locally for us, treatment and access for dual diagnosis, access for psychiatry if we have individuals on long-term benzodiazepine use or just really suffering with some mental illness. That access is very difficult and a challenge. I know prior authorizations can be a challenge at times, not anything that we can't overcome, but I think that our team back in Beulah can speak to that if there's questions on that. And then, of course, FQHCs and telehealth reimbursement. We could sure increase access to additional sites that we provide services to. But, for us, we have a clinic twice a month in Killdeer, and that is an hour away from our Beulah clinic. And so 2 hours is spent a day traveling, where we could see, X amount more patients if we had that telehealth capability for reimbursement. Is there anything else back from Beulah, our team, that I did not touch on that you guys would like to touch on?
Great, thanks
No,
much. Well, go ahead, Dr. Jackson.
I think you've covered it. I just really appreciate all the assistance that Heartview has given us. And without them showing us the ropes, I don't think we would have been a success. But the things that we've done, including starting a secondary clinic at Killdeer and branching that way, I think it's just phenomenal. Raise both Heartview and Coal Country enough for what they and we have been doing.
And now you trailblazers are being followed by Valley Community Health. What's that been like, Betty, for your shop starting out? I know you've got a few cases now of medication-assisted treatment.
I'm here with my team too as well. I've got Lisa and Chris, who are waiver providers, Kristen, who is our MHT care coordinator, and Angie, who's an RN care coordinator. Well, we got started when Chris, and I believe you, Dr. McLean, went to Maine and brought back Vermont, brought back the information. But one of the biggest, I think, impacts that we had is we had all of our staff that were on board. Well, most of our staff that was on board wanting to do this, so the information was brought back. We have started. May 1st was our first time. We've had a few patients. We also were the ones who were like, no, we're not going to do inductions for a long time. And just last week we decided, I think we're ready. So we're doing a slow and steady pace for that. But I agree with Chastity, the training, the ability to go see other agencies that had already started. We went to CMS in Fargo. We're able to tour that. We went to Heartview in Bismarck. A few of us went to Coal Country and Beulah. Bring all that back here and figure out a way that we're going to set up our program based on what we need. And what we can do. We are a primary care clinic as well, so our providers are very busy with their panel of patients for chronic illness, but what we saw and brought back is we realized that the patients we saw there were already our patients that we're treating, so why wouldn't we treat another impact or another part of their puzzle to getting them to be healthy? And that's part of our patient-centered medical home that we're trying to strive for, is being that hub, being that primary site, that one-stop shop. We also have a dental clinic, so we're able to provide mental health, we'll provide primary care and dental and oral. We have our integrated behavioral health that we've had for a few years now as well, that has worked tremendously in our primary care, so that we've incorporated into our NAT. And then just earlier this year, we brought on a psychologist, so we have the specialty mental health as well. So that has been tremendous. The training, the waiver training, all the nursing staff went through that. I think that was great. And then being able to call staff, Crystal, the nurse at Heartview, is awesome. Her and Kristen talk regularly and provide information back and forth. And Coal Country has also been wonderful too for our providers to be able to call and use that easy button for questions that we have, whether it be email, face-to-face, and then also having the collaboration with you, Dr. McLean, on a weekly basis for providing that expertise on some of our tough cases that our providers may have. Some of the barriers or challenges was, again, how do we incorporate this into already a busy primary care? We needed time just to make sure that we were getting all our policies in order, SQHC rules, how we're going to do this in our Epic EMR system. Do we do it paper? Can we incorporate it into an EMR system? And also that referral to treatment, which everyone has talked about, is we don't have a lot of places for treatment. Where can we send them? Or if we do, when can we send them? A lot of patients that come in already right now, and if they're told they have to wait a couple of days or even longer than that till it's staffed, then when that comes up, the patients then decide that they don't need residential or they don't need IOP, those kind of things. But I think we are learning as we go, and every patient that we see provides us with some type of ways to learn and better our system, and we're excited to see what's going to come in the future.
Great. Kristen, thoughts on how it's been for you?
It's been great. I mean, I think one of the biggest things we had was a team that was really supportive and bought into the idea of MAT from the get-go, from the time we got back. So that there was not a big sell from the top down in our organization to do it. I would again echo the being able to have those relationships with Heartview. I know I've sent between you and Dr. Henke, I send probably weekly emails with questions or what to do, and always get just a very kind and very useful response to help, and we haven't had to turn anybody away or not know what to do next. And then the nursing staff, I mean, the bulk of the work I give to them. Our MAT care coordinator and our nursing care coordinator do a lot of the pre-work. They do the intakes and the health histories and the drug screens and the random pill counts and all the things that make our visit just sort of super smooth. But I think it's been really useful to patients. I think we also had a little bit of this, what's our waiting room going to look like? What kind of clientele are these going to be? And it is nothing like nobody's worst nightmare at all. It's just any one of our other patients that walk through the door that just have another chronic disease that we're helping them cope with. So
Right.
I think it's been.
Yeah, and it really is a community of helpers and colleagues. You know, we've got Wendy there from CMS who's joined us all the time, and she has welcomed people in, and also some of our residents, psychiatry residents and medical students, Heartview as well. Pat from Blue Cross, you heard some of the issues of our comments about prior auth and the ways in which they can expand. And then also you very likely have a good lay of the land across North Dakota with primary care and what the issues are. Thoughts?
Yeah, well, I guess I have a few thoughts. My background is primary care, and the program I work with is really that Patient-Centered Medical Home Foundation. So I appreciate Chastity and Betty, who both know very much how that works, and you guys have done a great job of being able to integrate that behavioral health. So one of my questions is always, because the program that we work with for Blue Cross Blue Shield is a primary care program, but we're introducing a measure this next year on screening for alcohol and substance abuse, as Chastity and Betty both know. And one of the questions that I get across North Dakota for some of the clinics that aren't as well versed in this, in starting the process as these two groups have, is really that starting of screening. And there's a lot of, as Chastity even mentioned, even just with the MAT, but there's fear in even screening for alcohol and substance abuse. And I guess I'm right now working with clinics that are just getting going on how to ask those questions and how to start that process. And then of course from there it goes into, really doing that screening and interventions and all of that. But I think from what I hear, there are clinics in North Dakota that haven't been routinely screening. And so I think just my questions and really my comments are really more about the very, very basics of starting this process and how that education happens, and then how that education translates for sustainability. And so I know you guys have done this and thought about it. So I'd like to call it back to Chastity or Betty to talk a little bit about how you guys have done that when there's turnover of staff and just that, screening tools. There's a variety of them, and how do you get that started in a busy primary care clinic?
Yeah, so I'll answer that, Pat. And I guess I forgot to talk about Blue Cross Blue Shield too, and what recently happened with some additional reimbursement. So I'll touch base back on that. But as far as the screening goes, depression and anxiety screening has kind of been longstanding for us. Depression being a measure that we have been working on for several years. The North Dakota Department of Health had offered a suicide prevention grant years ago, and that's where we began. And then HRSA kind of has come along with that with depression screening as well. But when we began the MAT program, we began screening all patients 12 years of age and older, co-screening them with a KJ, doing alcohol and substance use screening. And I think that common screening of always screening for depression and anxiety, we co-screen for that as well for 12 years of age and older. That kind of has just become part of what we do with our rooming process. So it's part of our orientation process. It is from our board of directors down to our CEO and our medical directors on down to our clinicians and our medical home teams. It's just part of, if you're talking about medications and allergies, we're also screening for depression, anxiety, alcohol, and substance use. So I don't think it's been difficult for us. It's just now kind of become part of our culture as screening. And yes, questions are not so comfortable to have with your, next door neighbor or your, your pastor at church, but they're still part of a whole person assessment when they're accessing primary care and really part of that medical home model. So I also will just add that Blue Cross Blue Shield did work with us, and we really were able to give a lot of input on the time that our nursing staff and our care coordinator, our behavioral health care coordinators spend on patients that are accessing care from MAT services. And so with this last year, we were able to have an additional revenue from a care management standpoint for all of the care that is provided kind of outside of that face-to-face with the patient and the physician. So that has been, I guess, a plus for us to continue to expand our program and expand our resources for the provision of MAT services in our communities. So that is a huge thank you from the reimbursement standpoint.
So this is Lisa Faust. Can I just ask a clarifying question about the barriers that I heard regarding prior auth and the amount of time it takes? I'm not sure. I'm trying to sort of orient myself to what that is. I'm not aware, at least for Blue Cross. Maybe this isn't an issue with Blue Cross, but we don't prior auth meds for MAT, and we don't prior auth the outpatient services. So am I missing something, or are there barriers with other payers that you run into that maybe we don't offer? Can anybody speak to that?
Yeah,
Dr. Fox.
Go ahead, Betty.
Thanks, Chastity. I'll let Kristen, our MAT care coordinator, take that one because she's the one that deals with them directly. So here she is.
So I would say for us, the North Dakota MA, Minnesota MA, and then Stanford expansion all require different things for their prior authorization. It is often unknown necessarily what they exactly want from us as the clinic until we send it in and then get the denial. So a lot of times it's been a learning process, but it is resubmitting the claim until we kind of finally get it right to what they want. And then hopefully it can be submitted in a timely manner so that our patients are taken care of. I know with North Dakota MA, they do get a 3-day urgency fill before their prior auth goes through. However, that's not the same with the other insurances that we've come across.
So primarily it sounds like it's related to the pharmacy part, the medication component that you run into. And I certainly can't speak for other payers, but I think in general across the industry, part of what is important is that we want providers to be able to be, if you will, payer blind, so that ideally the future state that we want is that everybody treats it the same way, so you're not trying to operate with different rules for different payers, because that sucks up a huge amount of resource for you, and we do recognize that.
Other thoughts, comments? All right. Well, Dr. Ryan, thank you very much. I imagine you're probably gone. No, there you are. You're still there. Okay. So we'll see you shortly.
I will be on my way.
All right. And for the panel members, our thanks again for stepping forward and for all the great work that you do. We'll be meeting again in a couple of weeks. Just want to remind people to fill out the post-test and also the evaluation that we'd like to see. And then as mentioned, for any of you in the area, if you're able to make it to the Rural Health Conference, it would be great to see you. And otherwise, I don't have any other issues or comments. Anything else for the good of the order? All right. Thank you very much. Have a good rest of the week.
Thank you.
So amazing that listening to this instruction.